Welcome to this webinar on getting started with VEMP. My name's Darren Whelan and I'm just going to spend a few moments just to give a bit of background to VEMP assessment and some of the physiological pathways related to VEMP before we do a bit more of a deep dive into the cervical and ocular VEMP measurement. VEMP itself is short for Vestibular Evoked Myogenic Potentials. So these components come together to explain to us what we're actually assessing when we're performing a VEMP measurement. So vestibular allows us to know that it originates from the inner ear structures, so part of the vestibular peripheral organ, and in fact we'll talk a little bit more about this in detail as we go through today's webinar, but it's from the otolith receptors within that vestibular system. We evoke these responses most commonly in clinic by a stimulus such as air conduction, but we also perform bone conduction, so we can actually measure VEMP under vibration. In some of the earlier literature, if you've touched on some of this, you'll see we've used tendon hammers and mini shakers to elicit some of these responses. They're myogenic. So in the world of audiology, that's something that's a little bit of a sidestep to what we're normally used to measuring. These are recorded directly from the muscle. So a little bit different to an auditory potential, although we are measuring them on EP systems, so evoked potential systems that we typically use for auditory potentials. So they do behave a little bit differently. And again, today, we're going to take some moments to actually discuss that in a bit more detail in relation to both the cervical and the ocular VEMP. And it's a potential. So a lot of the potentials we measure in audiology are things that change in state. So we stimulate, there is a change in state, and we measure that difference and actually look at that as a reflex or as an electrical impulse. Now, we have been aware of sound-evoked vestibular responses for quite some time. In fact, Tullio, which some of you may be familiar with, described this concept of acoustic sensitivity of the vestibular end organ way back in the early parts of the 20th century. And again, another founder of vestibular science receiving a Nobel Prize shortly after, a few decades after Robert Barani. And then later, as research developed and technology developed to sort of look at these structures in a little bit more detail, we see von Beckershey receiving a Nobel Prize for also looking at vestibular responses in normal human subjects. And it's really at that turning point where looking at sound-evoked muscular responses started to gather momentum in the research. And obviously today is really a bit of an introduction, so we're not deep diving into any of these research, but I think it's very useful to have this in mind when we're actually looking at where do some of these assessments come from. And as technology evolves in the latter part of the 20th century, we get to the state where we are now, where we're now recording these with evoked potential auditory detecting systems with specific stimuluses that we can use to elicit the responses and protocols to maximize the potential of actually recording some reliable results. Now, in relation to where these muscular responses fit in, really these comprise a lot of the vestibular spinal tract reflexes. So we see these throughout the body. So interestingly, you could stimulate the ear and actually record a myogenic muscular vestibular mediated response from the central nervous system right the way down into those calf muscles. So when we're looking at patients with postural instability, for example, it's part of that very similar network that may be regulating and manipulating some of these muscular responses. So let's now start to get into what we're talking about today, the actual components of what comprises a vestibular evoked myogenic potential. So starting with cervical VEMP, we probably know a little bit more about cervical VEMP. They've been around longer in the research literature, and clinically we've been utilising these for a much longer period relative to ocular VEMP. We know from studies that these are a record of function of the saccular and inferior vestibular nerve, and that's important because actually this is where we start to look at different components to the inner ear and vestibular end organ. The oVEMP, again, along the same sort of pathway, actually records the function of the utricular system. So now we're actually looking at the otolith system in two different ways, both the utricular system and the saccular system, both detectors of movement relative to gravity, and certainly in linear type acceleration. Now this utricle system, we know from earlier work on the physiological innervation of the inner ear that the superior vestibular nerve has the largest component there. And what does that look like if we look at that as a sort of diagram? Well, if we look at the oVEMP, this utricular superior vestibular nerve also being tied in with the ocular movement of the eye, so we can see that there being highlighted, and the cervical VEMP being a saccular and inferior vestibular nerve innervation. So let's look at the pathway. So for a cervical VEMP, the reflex pathway is really from stimulating the ear from whatever technique we've used, through the saccule, and if we simplify this, it's the inferior vestibular nerve up into the vestibular nuclei, down the vestibular spinal tract, through the spinal accessory, and then into the sternocleidomastoid mastoid muscle, which often we'll refer that to as the SCM muscle, so the sternocleidomastoid mastoid muscle. And it's at that muscle in the neck that we'll measure the actual response, and again, you get to see that in a short while. So these are ipsilateral responses. So in other words, what we're saying is if I record it, I stimulate the right ear. So I'm recording from that right ear. I'm actually also recording from the right part of the neck muscle as well. Slightly different, but along the same parameters, the ocular VEMP reflex pathway. Again, this time from the right utricle as an example, up the right superior vestibular nerve, again into the vestibular nucleus, along the medial longitudinal flacculus, down to the ocular motor muscle, nerve pathway into the muscle, and then we record it from underneath the eye, from the inferior oblique muscle of the eye. So quite a small muscle. Now what's interesting, particularly in the ocular VEMP, is we can get ourselves a little bit crossed over here because it is a crossed response. And by that I mean if we're now stimulating the right ear, we're actually measuring that underneath the left eye. So we do have to make sure that we get our electrodes positioned correctly. And again, we'll show you that in a bit more detail later today. So before we get into that, well, why record VEMP responses? Why are we looking at the otolith organ? Well, actually, this is it's an interesting concept, really. We have a lot of background in recording semicircular canal responses. If we go all the way back to caloric responses of stimulating single ears or rotating people in chairs, for what is now probably the better part of just over 100 years, we've been looking at eye movements relative to stimulation of the semicircular canal. But the vestibular end organ has the otoliths in there as well, and these all work in a very synergistic fashion. So we need tests that actually can cross over and cross-check the systems. So for example, as you can see in this table here, the caloric response can be normal when there's no impairment, so normal caloric response and normal cVEMP and normal ocular VEMP. But if we take an example here which would have a utricular involvement, we may have normal semicircular canal function. We might have a cVEMP that's normal because that's a saccular function, so I'm looking at type 6 on here. But we've got an abnormal ocular VEMP, and that's indicating that there's some functional change in the actual utricle system. So we can use this to actually look at various different components of the vestibular end organ. And if we move a little bit further to newer technology of looking at semicircular canal function, more at the physiologic range of head movement, again we can compare that with VHIT in a similar way of looking at semicircular canal function relative to otolith function as well. So let's just take a very quick look at cVEMP montage. So what you can see here is we have a recording where we're recording from both the neck muscles, a ground on the lower forehead, and then a reference somewhere on the clavicle. Now you'll see in this example, those that are sharper eyed amongst you, these ones on the sternocleidomastoid mastoid muscle should really be relatively symmetric. And in our example here, they're not quite where they would need to be. So really we'd want to level those out so the right and the left are in a bit of better proportion. Where to place it on the muscle? Well, it's in about the top third of the sternocleidomastoid mastoid muscle. And we have to be careful. If we do place it too low and in the wrong position, we can find a null point where we're not going to actually record the response from that muscle. In a typical cVEMP, we're looking at this biphasic wave where we have a positive then a negative component. And these will be from the myogenic potential of the muscle relaxing and recontracting in relation to the stimulus. And that's what they'll look like on an Eclipse system when we measure it. And again, you'll get to see these a bit more detail in a moment. So for the cVEMP, we've got some latencies that changed a little bit depending on the stimulus, and actually age as well can change the latency, draw it out a little bit, make it a bit later. Amplitude actually varies relative to the EMG of the muscle response, so we do get quite large amplitudes, much bigger than in the auditory evoked potential. And really what we're looking at is the presence or absence or asymmetry between them. We've got a couple of other things that we would look at as well, but we'll save that for a later webinar where we really deep dive into the more advanced tests on VEMP measurement. So in terms of the oVEMP and the montage, now we're looking at a slightly different montage. This may be the more traditional montage that you've seen in a lot of the early literature, having the ground on the forehead, the collection and reference electrodes very close to one another on the cheek. What you'll see in today's webinar is we'll actually look at this alternative montage, which has now come through the research of placing the electrodes, and you can see here we've got the left electrode under the right eye and the right electrode under the left eye, so to take into account the cross response, and we have a reference right on the forehead here, just actually at the top of the bridge of the nose, and we can place that ground on the high forehead. To get the ocular VEMP response, we do need to elevate the eye, so we're not turning the muscle as we do in the cervical, we're actually raising the eye, and again I'll deep dive in this a bit later for you. What does it look like? Well, typically what you're going to see is a response where we now have a negative and a positive peak, because it's an excitatory response, not inhibitory like the cVEMP, an excitatory response where the muscle's actually going to jump and then recontract again. And on the Eclipse, we'll be looking at something that has a morphology such as this. It may change if you look at the moment we use a 10 microvolt scale. If we put it on a 2 microvolt scale, you see that much more clearly. In terms of interpretation, very much the same. We look at latency, amplitude, which is smaller because we're measuring it from a smaller response, and again symmetry between the two sides. So why record VEMP responses? Well, apart from the cross-checking of peripheral vestibular function, there are certain conditions that actually show up quite nicely when you're looking at otolith function, such as superior semicircular canal dehiscence, which there's a lot of research about, and where we have an opening of the inner ear structure that's allowing sound to pass through into the vestibular end organ rather than being completely directed where it should be, through into the cochlear structures. We have things where we might have otolith involvement in bilateral vestibular loss. The days of calling bilateral vestibular loss based on one test are gone, I hope, so we do cross-check with things like V-hit, canal responses such as the chloric response, rotational chair if you have that available, and also the otolith function as well, to see exactly how much functional change has occurred in the peripheral system. Again, touching on it very briefly today, but maybe reserved for a more deeper dive, we can look at the presence of hydrops, so endolymphatic changes in that peripheral end organ that may show up in some presence of tuning of the response, moving it from where we would expect it from physiologically to a different place in terms of the stimulus frequency. So just to complete, looking at clinical applications, we've talked about utricular function, saccular function, semicircular canal dehiscence and Meniere's disease. But obviously amongst all of these, we're looking at otolith function, so anything that can disrupt or change otolith function. So that could be things like the inferior vestibular nerve or superior vestibular nerve, or even conditions such as vestibular schwannomas, where we've got something that's being space occupying and affecting the nerve function and affecting VEMP. As far as we know in the research so far, there are no real gender differences in terms of the VEMP characteristics. Age does change the VEMP, and that's more about the muscular response, but again, we're now getting techniques where we can measure VEMP in a much older adults, and EMG is quite important, so we need to have something where we can measure the EMG, particularly in the cervical VEMP, so that we can actually get the EMG level up to a high enough level to measure that inhibitory response. And again, we now have systems within our EP systems that allow us to monitor that. So that brings us to a conclusion of the introduction, so now we can move into actually the application and looking at a much deeper dive.